Okay, let me mute everybody. Hold on a minute. Peter, you hear me?
Can you hear me?
Yeah, okay, there we go. Okay, so I've muted everybody so they don't interfere. Everybody, good morning, good evening, and good day wherever you are. It's a pleasure today to have Peter Valentine join us from Guildford, United Kingdom. Peter participates in the Ethiopian program with Misha and has been doing that for a couple years now with Global ENT. And we're delighted today to have him with us. He's going to talk about endoscopic ear surgery starting out. So with that said, Peter, please take the microphone, and we look forward to what you have to share with us today.
Oh, thanks very much, Richard. May I send you all my greetings from Guildford in England. I'm 30 miles southwest of London. It's 9 degrees or 48 degrees Fahrenheit. It's raining, it's miserable, and being an Englishman, I did use my umbrella today. But what I'd like to do is to talk to you about endoscopic ear surgery, which we all know is a minimally invasive way of entering the temporal bone, essentially by an enhanced permeatal approach. Now, you can operate it with the endoscope in the ear as an adjunct to the microscope, or entirely use the endoscope to carry out the procedure permeatally. Now, clearly, like any technique, it is not appropriate for every patient. And there is a maxim in surgery that you really want to use a screwdriver for a screw and a hammer for a nail. And it is a case of using the appropriate technique for the appropriate patient with the appropriate disease profile. Now, a lot of us encountered endoscopes in our rhinological training. And the skills that we use there in terms of the using of the endoscopes within a body cavity are fully transferable to the middle ear, and is something that you will find when you do take up the surgery very familiar. There's a recent paper from Nimal Patel in Sydney in Australia, where he looked at the costs of carrying out limited attic cholesteatoma surgery with the microscope or with the endoscope. And interestingly, there's a cost saving of 3,000 Australian dollars per case in a private hospital. And the procedure was, on average, 56 minutes quicker. Now, clearly, there are also the indirect cost savings of the fact that you can have faster discharge, faster return to work, and the patients have less post-operative nausea and pain because you're not having a post-oral incision. And so, in terms of developing countries, using the endoscope may be a cheaper setup with capital costs for actually doing surgery than having a full microscope suite. So one is using the endoscope to enter through the narrowest part of the ear canal to give you a much wider field of view of the middle ear. And these are Mues Tarabishi's original drawings from his early papers. The downstream benefit of this is that you have greater healthy tissue preservation. Of course, because you are operating down the ear without any outside incision, you have less pain. As I said earlier, return to work, better cosmesis without a post-oral scar, and less chance of a wound infection. The advantages, of course, is that you have exposure of the hidden recesses that standard microscopic approach cannot provide, namely the facial recess, which is lateral to the facial nerve, and the sinus tympani that is entered inferiorly from behind the stapes. And if we look at some of these areas here endoscopically, you can see that you have the caudal ridge here, which is important to find when you come to elevate posterior pars tensor retraction pockets. That is the inferior aspect of the facial recess. And below the caudal ridge, one has the lateral sinus tympani. Now, one can see here the pyramidal eminence through which the stapedius tendon comes. And if we look more anteriorly, this is the sinus tympani up underneath the ponticulus. The subiculum is here, and in the area essentially medial to the stapedius tendon is the posterior sinus. Now, cholesteatoma in the retrotympanum can enter all these areas. The sinus tympani can have a variable depth. So this is what is called a grade 1 sinus tympani, but it can also extend to be retrofacial. And sometimes you have to do a posterior approach to drill out the area to clear the whole elongated sinus tympani of cholesteatoma. Obviously, to access the posterior sinus for clearance, it's best to divide the stapedius tendon to help you access that area. So what is integral to the surgery is actually the Hopkins Rod. Now, a lot of people think that the Hopkins Rod was named after John Hopkins in the United States, but actually Harold Hopkins was a professor of optics at the University of Reading in England, who also designed the zoom lens for cameras as well. If you were to open up an endoscope, you'll find that you have a series of glass rods that are separated by small air gaps, which then provide this system of total internal reflection, where you have this seamless image. Around the outside of the endoscope, you have fiber optic bundles which are transmitting the light from the light source. So they are separate from the image that you see, but obviously do not have the pixelation that you see on a flexible nose endoscope. The advantage is that you have a wide field of view with high clarity and also very high resolution. The options that you have for certainly endoscopic ear surgery are the 4 and 3 millimeter. I prefer the 3 millimeter. It gives you more room, and one can have a prism at the tip of each of the endoscopes that allows you the angulation to see more clearly into the various niches of the middle ear. The xenon light source is obviously a cold source light, and ideally one wants a high definition camera with a high definition screen, although a 3-chip camera is still suitable. The issue with the endoscopic image is that it is actually 2-dimensional. But because you're continually moving the scope within the ear, the subtle changes in the field of view when processed allow you to configure a 3D understanding of the operative field. So it is important that you don't strap the endoscope down or try and work from it from a frame, because you actually rely on those tiny movements of your left hand in which you're holding the endoscope to allow you to form that 3D understanding. One has spherical distortion because of the lens, which means that the periphery is more magnified than the center. And obviously you can get variable magnification according to the distance at which you're looking at the object. The other issue to understand is parallax with the angled scopes. So this is looking with a 0-degree scope at a combined approach that I did a year beforehand. You can see the laser that I've used to remove the cholesteatoma. So there's no parallax with that. You can reach straight ahead and it's a true view. Now this is using a 30-degree scope. And you can see, because of the angulation of the tip, you can rotate it and look around into various niches that you see with the xeroscope. But because of the parallax, you'll have to reach up to grab the image. So it is technically more difficult to operate with. And with the 70-degree scope, this becomes much more difficult to actually operate because of the parallax, but allows you to see around the corners. And clearly it is very difficult to have control over your operating hand with a 70-degree scope. The most important thing with operating with a 70-degree scope is that you watch it into the ear and then you look at the screen. You can easily just accidentally hit a stapes by trying to look at the screen when moving the scope into the ear. So may I recommend that you watch the endoscope into the middle ear, and then you look at the screen, and then you could just check the endoscope by looking down it as well. So if we talk about starting out with endoscopic ear surgery, the very great difference that you have with compared to the microscope is that you have only one hand free for surgery. You are using the endoscope with the camera in your non-dominant hand. And this is obviously the hand that under the microscope that you'll be using the suction to clear your field of view. So you are alternating between dissection and suction aspiration. And you need to have somebody assisting you who knows what they're doing, because they will be passing you the instrument into your dominant hand whilst you're looking at the screen. So you don't want to have the sister who sometimes does orthopedics and sometimes does general surgery. You really want to have somebody who you're familiar with working with and understands what you're trying to do, and is also looking at the screen as well. So with your setup, you want to have the screen so that it's at a neutral position with your neck, so that you're at a comfortable position with your neck, so you're not going to get fatigued during the case. Ideally, you want to have your imaging so that you can see it. You want to have support for your elbows. And if I was operating on the other way around with the camera, I'd have a chair with an armrest to support the weight of the camera. And that again reduces fatigue and also enhances some dexterity. I use the 14 centimeter, 3 millimeter Hopkins rod. If you use these 6 centimeter rods, you don't have enough angulation to get your operating hand adjacent to the endoscope. But the 14 centimeters gives you enough clearance from the camera to get your operating hand in. So with the endoscope, bleeding appears considerably magnified, and you want to do everything that you can to minimize bleeding in the operative field. You would like to ask your anaesthetist to give a decent hypotensive anesthetic, and by elevating the head of the bed in the reverse Trendelenburg position, you're reducing the venous pressure to enhance to reduce the chance of bleeding. Preparation of the ear canal skin is essential, and it can be worth injecting the ear before you scrub for the case to allow time for the adrenal infiltration to work in the canal skin. Also, you can pack the ear canal skin with 1 in 1,000 adrenaline impregnated ribbon gauze and leave that as well. With operating, the most bleeding occurs when you're raising the tympanomeatal flap. But generally, once you're in the ear, the bleeding is less. Occasionally, you can get some bleeding from the edge of your tympanomeatal flap. If that does occur, just pack it, wait, and leave it. Now, the other thing that can occur when you're operating is that you can get quite a lot of red out as the blood drifts onto the lens. Just regularly irrigate the ear with warm saline. That also will have the effect of reducing the misting of the scope as well. If you wash and then pack with adrenaline, that is the most effective way of controlling the bleeding. And with the adrenaline pates, just be patient. Pack it, watch the clock, wait for 2 minutes, and then take it out. Don't just take it in, put it out, take it in, put it out, because it will carry on bleeding. The next issue is that you can experience quite a lot of misting or smearing of the lens that upsets your view. This can be helped by warming the endoscopes preoperatively, because it is the humidity of the middle ear space that causes it to mist. I'd recommend you got a good quality anti-fog solution. And throughout the case, what tends to happen is that you can build up some fat on the end of the lens that then smears when you'll use the anti-fog. Every so often, if you just clean the tip with an alcoholic wipe that can take the fat off the end of the lens and make it clearer. I would recommend shaving the tragal hair and the ear, the external traumeatal hair, exactly the same way as you used to do when you did a rhinoplasty, like shaving the vestibule. And what I tend to do is I tend to use some stay sutures to open the ear up to prevent you trying to sort of touch the meatus as you're moving the skin in and out of the ear. And I have the, I'm right-handed, so I have this on my left hand to clear the end of the endoscope. But shaving the hair and using these two sutures can improve your chance of keeping the end of the scope as clean as possible. So look, what was the first case you ever did under a microscope? It was putting a ventilation tube in. So may I recommend that the first case you ever do with an endoscope is put a ventilation tube in, because it allows you to practice with the skills that you need to do more complex surgery. So if you're starting out, do a list of tubes with an endoscope and see how you go. And you really want to start with a graduated approach to complex cases. Start out by removing some earwax, then put some tubes in. And then as you move through, you want to select favorable cases to start. In other words, a nice posterior perforation with a widely patent canal with no evidence of infection or granulation to minimize your chance of bleeding. You really want to work yourself up through your cases. I use Thomassin oto-endoscopic instruments. These are available from Karl Storz. You can see how well used they are. They've been in and out of the autoclave for years. There are other instruments that you can get. These are the Panetti instruments that are all cannulated and attached to a sucker unit and are a great way of keeping the ear clear of blood. The International Working Group are standard instruments, but they do give you instruments that you don't necessarily need. But using the Thomassin kit is to get started with is essentially what you need to get going. Within my personal practice, I use endoscopic approach for cartilage tympanoplasties, particularly when there is an anterior perforation with an overhanging anterior canal wall, for which I would previously have done a post-auricular approach. I use it for deep posterior pars tensor retraction pockets and mesotympanic cholesteatomas affecting the retrotympanum, where previously I would have done a canal wall up surgery, drilled a posterior tympanotomy, and cleared the disease that way. If you have limited lateral epitympanic disease, I tend to use this approach, widening the attic erosion with normally a curette, although you can use the 2 millimeter angled diamond burr that's available on a Medtronic system. I use it as an adjunct to the microscope if I am doing a canal wall up surgery. I do an endoscopic second look a year down the line for my Cat 1s via a small post-oral incision to re-examine the mastoid cavity. And it's great for congenital cholesteatoma in kids who have small cholesteatomas in the anterior mesotympanum. An interesting recent meta-analysis of 13 studies in the American Journal of Otology found that there's, looking at 13 different studies, that there's significantly less residual disease in looking at endoscopic clearance of cholesteatoma versus microscopic, obviously because you're accessing the niches, but there was no difference found in either the graft take rates or the hearing results. So this is a video that I took of a perforation, an anterior perforation that I freshened the edges of. And I just want to show you a slight change in the way I raise the tympanomeatal flap with these. So obviously one makes an inferior incision. Now you can see that I've prepared the canal skin very well, and this is the initial incision. So there's hardly any bleeding, and this is because I infiltrated the skin before I went to scrub up, and I packed the ear with adrenaline impregnated ribbon gauze, And my anaesthetist is very good at giving a hypotensive anesthetic. So we're raising making a incision superiorly here. And essentially what I'm going to do is I'm going to make an inferiorly based flap. So just going lateral to the annulus, I'm going to make an incision from 9 o'clock all the way up and over the top to above the attic, which you can see here. So not much bleeding at the moment, but clearly in an ear with infection, it does bleed more. So using a sponge here with adrenaline, this is an ophthalmic sponge that I use from iTech, which is cut into lots of little pieces, into lots of little cubes. It's nice to use this as a pledge it in the ear. So just ascertaining where the chorda is, which you can see there. And what one is trying to do here is find the lateral process of the malleus and develop this plane here, because you're wanting to strip down the drum from the malleus inferiorly. You divide the middle ear mucosa medial to the annulus anteriorly. And if you hold the top here and gently pull downwards, it does undo like pulling down a zip until you reach the umbo, where then you have to, if you are going to remove it, you have to cut it with a pair of forceps. And again, use the Thomassin instrument, you can just move the drum down. Try and avoid traumatizing this area here, okay? Because if you get a hematoma, it makes it much more difficult. So then I've prepared a tragal perichondrial cartilage island graft with the perichondrium lying laterally. You're moving the graft into a position so that you can feather the perichondrium over the manubrium posteriorly and up over the anterior canal wall anteriorly. And this will then hold the graft in place. Now, as we all know, this is typically an area that is, if you're going to have a graft failure with temporalis fascia, it's always the anterior superior quadrant that gives. But this is a very good technique of supporting your cartilage in an area where the take rate is slightly poorer. And then you can pull your drum back and just make sure that your perichondrium is lying medial to the perforation. So that was with a sort of overhanging anterior canal wall, and the graft in follow-up took well. So if we look now at, this is a right ear in which there is a posterior pars tensor retraction pocket. This is the manubrium here and the anterior segment. So one's looking to lift up the flap. And you really want to approach these posterior pars tensor retraction pockets from inferiorly and superiorly, and work on a broad front to try and deliver the whole pocket out of the facial recess. So this is the inferior aspect here of the facial recess. You can see that coronoid process. So you can see that that's where the retraction pocket is going up. So this is the plane that you really want to try and develop without tearing it. And then if you come superiorly, you want to try and find the chorda tympani and go above the chorda tympani and develop that plane superiorly. And then as you start to curette this area off, you can then start to see the posterior aspect of the retraction pocket, that again, you're moving on a broad front. You can use the curette to give yourself some more access. But obviously the larger the area that you make, the larger your reconstruction is going to have to be. So using the 45-degree angled instrument, which gives you a little bit more length, you can see here's the facial nerve. which is not dehiscent. And what you're looking at doing is trying to find where the stapes is within the retracted area. So you're trying to find some landmarks. You're going to be looking for the pyramidal process here. You can see the chorda tympani there. And that's the bottom of the facial recess there. So just, there you go. Now, taking the matrix off the stapes, you really want to try and, in your the direction in which you dissect is from posterior to anterior, so that the stapedius tendon supports the stapes as much as possible and minimizes any chance of dislocation. And sometimes, if you get a good view in this area and the stapes is heavily involved, I would switch to use the microscope so that you're using two hands, and that can have distinct advantages in this area. And then if you look with the 70 degree, you're making sure that there's nothing extending back into the mastoid, particularly in this area here, where essentially, which is the fossa incudus, where the incus has been removed from. So that's the lateral semicircular canal, and down here is the adductors ad antrum. So this is another case looking at clearance of the sinus tympani. This is quite a shallow sinus tympani. If you have a particularly deep sinus tympani where it's more difficult to remove the retraction from, I will use a small Zinni mirror and use a laser to vaporize that area. This is just using the laser under the endoscope to clear some areas. And you can see that with the angled suction, that you can see all the way into the sinus tympani and exclude any residual disease being there. So as I said, with my second look combined approaches, I use a small post-oral incision, and this is looking through the posterior tympanotomy at a Kurtz clip prosthesis that's placed on the stapes. And you can see you get a good enhanced view to ensure that you've got no residual disease there. So with endoscopic ear surgery, you want to try and get yourself on as many instructional courses as possible and meetings. It's very important you play yourself in. You start off with the easy cases, get familiar with preparing the ear canal skin, get familiar with the technique of working with somebody else handing you the instrument into your dominant hand. Ideally, if you have a senior mentor who could help you for case discussions, that's very helpful. And likewise, if you can have a radiologist who's interested in otology, that can help you in your case selection. And with anything that you're looking at developing yourself, it's worth auditing your results so you can go back and reflect on which cases went well and which cases didn't do so well, and what you would change to try and enhance the patient experience. But thank you very much.
Okay, Peter, thank you very much for an informative approach to endoscopic ear surgery. I'm not somebody who does it at this present time, but I found it very interesting. And I'm sure in the near future, I'll, indulge when the opportunity comes. I'm going to open up the opportunity for anybody who's now on the web link to feel free to ask any questions. I'm sure Peter will have a good answer for you because he had a very informative talk and explained it in a very, very simple way. So does anybody have any questions? You seem to have a question all the time.
I have a comment / question.
Okay, go
Um,
ahead, Misha.
thank you, Peter, for a great lecture. One of the things that I think is perhaps also very relevant to a global health setting is using the endoscope in outpatients. And I wonder whether you personally have experience of that in terms of photo documentation, because I feel that in a global health setting, not just for documentation, but also for communication and telehealth, we have an opportunity for either with a flexible or with a rigid endoscope, pictures to be taken of the ear and then transmitted to us, whether that's via WhatsApp or another format for good communication and diagnosis remotely. I also think from the point of view of training and also documentation of recovery afterwards, it's a great thing to be able to have. I mean, how many patients do we see in clinic once in a while where someone has drawn a diagram of a perforation or of a retraction and are trying to make an assessment of whether things have changed? We've moved on in medicine so much beyond that in so many other fields, but in ear surgery we seem a bit behind. So I'm just grateful for your assessment and input on that issue.
Yeah, I mean, I used to have an endoscope system in clinic before it broke in the NHS. We're now going to, within the next 18 months, the hospital's going to complete electronic patient records system, the Cerner system. So I was just meeting today with representatives from Storts who can fit a camera system into the clinic room, of course, to integrate with the electronic patient records and also with audio base as well. But I find it particularly useful for explaining to patients what a perforation looks like and why their ear's been discharging, and what a perforation is and what a retraction pocket is, as why we have got to do what we do. And if you can show them that the incus has been eroded, this is why you can't hear. And I think it not only gives patients the insight into what their problem is, but also allows you to teach people as well. I mean, when I started off, I used to look down the sidearm, the monocular sidearm of a microscope, and it was never quite focused properly. It was always a bit dirty. So if you look at that now to the HD cameras we have on the microscopes in theatre, to actually have the same facility to get a really good high definition picture of an eardrum can only facilitate teaching and sharing of information among colleagues.
Peter. Okay. Peter, let me ask you I want to ask you to address this. When the registrars are learning how to do sinus surgery, it's always with an endoscope. They're not using a microscope. Whereas when we learned traditionally ear surgery, it was always with the microscope, and as an adjunct to the microscope, we started to integrate the endoscope for visualization of the sinus, tympani, facial recess. And now it's progressed to the point where tympanoplasty and cholesteatoma, limited cholesteatomas, can be removed. I'd like you to address the situation where the new generation of residents is maybe under the false impression that you don't need a microscope, that you can do everything with the endoscope, because that's what we do in rhinologic surgery.
I think that, I go back to my comment at the beginning of the lecture. I think one should use a hammer for a nail and a screwdriver for a screw. And there are going to be those techniques that you can do with one hand and an endoscope. A lot of people are doing endoscopic stapedectomy. I would prefer to use a binocular view and two hands. I'm struggling to understand the distinct advantage that an endoscope would give you doing a stapedectomy, other than potentially allowing you not to take the posterior scutum down and maybe reduce the chance of injuring the chorda tympani. But in terms of actually doing the stapedectomy per se, I'm struggling to understand where the advantage of an endoscope would lie in that situation. I think, using an endoscope, you have to pick your cases. And I remember watching a a presentation where somebody was doing a cholesteatoma surgery of a what started off what looked like it was going to be a lateral epitympanic cholesteatoma that had actually gone all around the ossicular heads. And he proceeded to do a permeatal atticotomy with the endoscope, remove the whole ossicular chain, put in a prosthesis, and then had difficulty in then reconstructing with cartilage to fill the defect. Now, looking at that, my choice in that situation would have been to do canal wall up surgery to preserve the ossicular chain using the laser, and then have the control to put in a cartilage composite graft that I could steady and position to reduce the chance of recurrent disease in the future. And preserving the ossicular chain obviously maximizes the chance of the patient having good hearing. So I think, as one is trying to move ahead using the endoscope, because there are distinct cases in which it does offer an advantage, I think you've got to be careful that you have the disease process and the patient's best in mind. And for me to, if you have an ossicular chain that you can preserve and not take down in cholesteatoma surgery, that is for the best. But I just felt that this chap was wanting to push it with the endoscope and maybe was stuck in a bit of dogma.
My observation of watching numerous people do endoscopic ear surgery is that comparing to a microscopic, approach, is that they're doing a lot more than I would have done with a microscope. They seem to be, you're closer to the disease, and there's a lot more dissection and destruction before the reconstruction. That's my observation.
I don't think you're destroying. I think you're maybe making incisions and moving tissue out the way in a controlled way. And in fact, you're not making a large incision either endoral or postoral, which we with patients, we all see our patients who do have, there are a small degree who will have a permanent neuralgic pain behind their ear.
Right. The most important thing you said is you have to choose your patients. And I think for the young registrars and people getting into endoscopic ear surgery, you really need to be selective. If your CT scan shows, mastoid cholesteatoma with attic retraction, you're going to use a microscope there. Okay. You've got disease, extensive disease, whereas when you have, a small attic cholesteatoma with a retraction in pars flaccida, it's a different story,
Yeah, absolutely. And I'm in the advantageous situation of actually also using DW non-EPI as well. So you can put both the MRI that shows you the size of the cholesteatoma superimposed on the CT. Mm-hmm. And, there are some, because of course, in some situations where the CT can't tell the difference between fluid mucosal disease and keratin, that the cholesteatoma can, in some cases, be much smaller than the CT scan would suggest. But equally, you can have some cholesteatoma that are much bigger than you thought they were going to be. And this is a case of choosing your, if you are going to go for complete endoscopic surgery, choosing your case carefully. And the other answer, the other comment I have to make is that would I ever do an ear case that is not a perforation in a room without a microscope? The answer is no. I would always have it standing by. So if it's a straightforward perforation, yes, you could probably take it on without the endoscope in the room. But if I was to be in a situation where there's cholesteatoma involved, I would always have the microscope standing by and draped.
Appreciate the comment.
Peter, could I ask whether you have, there's a bit of interference. Do you have any experience with the exoscope, which is an externally mounted 3D scope, which and then you wear 3D glasses? We had one come into Guy's Hospital the other day, and it's obviously not something that's widespread, but I'm just wondering if you have an experience with that.
Only playing with it in the dissection room at Guy's.
Yes.
About a year ago, and it's quite fantastic.
So
Um,
it is amazing. So this is a device where you wear 3D glasses, and you get an incredible panoramic view because it comes with a huge HD screen, and you can have various different light settings. It isn't an endoscope in the sense that you can't put it down the ear canal and use. It's not small in the same way as an endoscopic ear surgery is, but it's much smaller than a microscope. So you haven't got all the faff around you, and you can still use two hands because it's externally mounted. I mean, this is like, you know, future stuff. But you know, I actually, as much as it's kind of quite cool, there doesn't seem to be an enormous advantage of using it compared to the microscope. You know.
no, but it's great fun though, isn't
It's good fun.
Who makes it, Misha? Is it made by Carl Storrs?
I think it's Carl Storrs. Yeah, I think so. Yeah. I'll have a look.
Does anybody else have any questions? Now's the time to get some really good answers to those things that might be of question.
In terms of the use of endoscopes in a global health setting, I wonder whether it's worth just doing a poll in the chat and just seeing who has even a flexible or a rigid endoscope accessible to them in outpatients. Is there anyone who doesn't have any sort of endoscope or flexible endoscope accessible to them that they could use with a screen? Silence. You can put it in the chat if you do or you don't. Just say yes or no.
There's some questions here. Saeed from Ethiopia said, "Did you use gel foam on the first case with the anterior perforation?" And I think he's asking, did you put gel foam underneath your perichondrial cartilage composite graft to support?
No, I mean that is the distinct advantage of using this perichondrial cartilage composite island graft, is that you use the lateral perichondrium almost like a hammock to sling your cartilage between the anterior canal wall and the manubrium, and so you don't have to have gel foam in the middle ear, particularly in that anterior area where obviously you have the eustachian tube that you want to try and get going as soon as possible after surgery. So it does have its distinct advantages to that.
Okay, and then Thomas from Latvia, or no, Thomas is from Lithuania. He said that indeed that device you're referring to is a Carl Storrs device. Okay. Oscar, do you have any questions from Ukraine?
Yes, just one question. Thank you for presentation, Dr. Peter. And my question is, are you doing right now less mastoidectomies after you incorporate endoscope in your practice?
Yeah, so in a situation where, for example, I have an extensive cholesteatoma, I will do canal wall up surgery. I will approach the mastoid portion posteriorly. Normally, if it's a large cholesteatoma under some pressure, what I will do is I will incise into the cholesteatoma and decompress the matrix or debulk the cholesteatoma, and that will allow me then to systematically dissect the matrix from the bone. If it's surrounded by sort of perimatrix granulation, I will then use the laser as the KTP laser that I use to help that dissection. I will then drill a posterior tympanotomy and then an extended epitympanotomy, which I'll then use a combination of the microscope and the endoscope to then clear. But really, the role of the endoscope comes in two places. That is the dissection of the cholesteatoma from the retrotympanum, which you can either do transcanal or you can do to a certain extent, so transcanal with the endoscope and using your instruments through the posterior tympanotomy as well. And the other area where it can also be very helpful is using the endoscope to clear the supratubal recess and anterior to the cog as well once you've taken that down. Now, to do that, you can raise an inferiorly based flap within the ear canal, stripping it down off the manubrium, and put your endoscope, the 45-degree endoscope, up through the anterior superior part of the ear canal to look into the supracerebral recess. So you're using your endoscope to either dissect or check the areas that we all know have the highest residual cholesteatoma or resivistic rate post-canal wall up surgery. And that's where the advantage comes, is in using it for its specific advantages.
Okay, thank you.
Peter, we have Saeed from Mekelle, Ethiopia, put in the chat that he has a 4mm endoscope. What do you recommend if somebody has a 4mm endoscope? What do you recommend for them in terms of approaching endoscopic ear disease?
Well, Saeed is, as we all know, so very nice to see you today. But Ethiopians are blessed with very nice wide ear canals. So Saeed shouldn't have a problem with his 4mm endoscope. And, you know, I used to use a 4mm before Storz brought out the 3mm. And I used to alternate between the 4mm and the 2.7. But the difference in the image and the light between the 2.7 and the 3mm is quite substantial. It's very interesting. But I would suggest that in Mekelle, 4mm, 0 degree. And when I come and see you next year, I'll be watching you using the 4 endoscope.
All right, thank you. Anybody else have any questions? Please?
Hello, it's me, Dr. Abdelaziz. I'm from Somaliland.
Okay, this is
Hello.
Aziz from Somaliland. Okay, Aziz, thank you. Please ask your question.
Okay, thank you, Prof. Peter. We have met in St. George's, London, and I have do endoscopic ESG. And thank you for very informative lecture. I've started doing my endoscopic surgery after the course, and what I have started is with my microscopic instruments. So is there 1 or 2 instruments that you will mention for me, so I will add to help me endoscopic ESG because now I have done up to 10-15 cases, 12 cases, and they are all doing good. Thank
Fantastic.
you. And so is there any specific instruments that I will need to add for my basic microscopic instruments?
Yeah, the instruments that I would really recommend are the Thomassin instruments. I think that if you were to have the 0 degree, the 90 degree double-ended Thomassin instruments and the 45 degree double-ended dissectors, those are really advantageous to helping you with your dissection technique. And also making sure that you have a long curved needle. The Thomassin instruments also come with an angled reverse hook that is very helpful for lifting matrix out from the retrotympanum as well. So the 3 instruments that I would recommend that you got if you wanted to spend your money wisely would be the 90 degree double-ended Thomassin dissector, the 45 degree Thomassin dissector, and the little 90 angled hook that is very helpful. You don't need to have the specific suction. You can use the Mediplast sucker and then use a mosquito to bend the tip or the end of the sucker into any angle that you want. So I wouldn't go wasting money on buying the specific Thomassin suckers.
Okay.
Thank you, Prof. Really appreciate it.
Okay, we have a question from Julian Ramirez in Colombia. He wanted to thank you very much for this lecture, and his question is as follows. Do you have any experience with endoscopic round window occlusion for, I believe it says Minor syndrome?
Yeah. No, I have never used the endoscope for that. I have done it a couple of times with the microscope, and the second time I did it, I got a dead ear, and I can't explain why I got a dead ear. It seemed, so I did it after a presentation at one of the AAO meetings I went to in the States, and it seemed like a very pragmatic, quick and easy way to deal with somebody with Miner's syndrome. But I obliterated the round window niche with some cartilage and then some bone wax. And about 5 days after the surgery, the patient ended in the ER with vomiting and got a labyrinthitis and a dead ear. So I haven't tried that one again.
Okay. Any other questions? You know, since we're talking a little about the round window, most books say that when you have otosclerosis of the round window, and I've never had a case of isolated otosclerosis of the round window, but I was thinking the other day, based upon Lempert, and first of all, is you can't remove round window otosclerosis. So why not create a third window? Why not do a lateral canal fenestration, okay, and see what the patient's results are going to be?
Yeah.
I'm waiting for the patient. Anyway. Okay, well, listen, I think our time is pretty much up. If anybody has any further questions and you don't have time now to ask them, please feel free to put them on the global platform. I want to thank Peter for taking his time to share his expertise and his knowledge with us. And I want to thank everybody for joining today. And we'll look forward to continuing next week, same time. Any questions, drop them down on the website. And again, thank you, Peter, for your time.
My pleasure.
Okay.
Take care, everybody.
Okay, bye-bye now.
Thanks,
Bye.
Peter.
Pleasure. Bye.